I am a doctor working as GH, Singapore General Hospital, for almost more than 25 years. And my journey started as a trainee registrar here. Now I'm a consultant and bring my service to the nephrology as well as to the community. For example, I also do some work regularly in dialysis centers, and I am involved in all sorts of nephrology, all points. But my main interest is in chronic kidney disease, mainly the preventive and early management aspect. That's my introduction. And I am well qualified and accredited according to Singapore Medical Council and also General Medical Council of the UK, as well as my own country. And I think that I will be able to give a little bit of brief but explanatory information about this chronic kidney disease to the community and to also our physicians community, which will include all doctors, not only nephrologists. Just for one information, that this chronic kidney disease mainly is caused by diabetes in 70% cases, and 10% cases is because of hypertension, 20% cases from other diseases like glomerulonephritis and other congenital and hereditary diseases. So major burden of the chronic kidney disease come from the community who are suffering from diabetes, and diabetes consists of more than 11 to 12% of the community population suffers from diabetes. So you can expect such a big load of chronic kidney disease in the community. Okay, thank you very much for inviting me for this very important subject of chronic kidney disease. I must tell you that this chronic kidney disease is not an isolated disease. It has been in the world for long time, and currently, according to statistics, about 10% of the population in general suffers from some sort of chronic kidney disease, which is in the literature, in the statistics, but the people might not know that. That's why this sort of communication is important for people to understand that they are among the group of chronic kidney disease, which has a big impact ultimately. If any one of them becomes in one of these 10 guys of his community or his country, is going to develop end-stage renal disease in course of time, requiring dialysis support or transplantation if available. So that's why this chronic kidney disease is important for the knowledge, for the health education, because this chronic kidney disease actually can be prevented, can be halted from progressing to end-stage renal failure. So that's why I was very much interested and supported this interview, and that's why thanks you. Actually, this is the main subject of chronic kidney disease. Okay, this is the slide where I am showing the different stages of the chronic kidney disease in terms of your renal function, that is GFR, and also in terms of the proteinuria, which is known as albuminuria in specifically. But I just moved to the next slide to show you the impact. On the right side of the slide, which I have enlarged, you can see the causes of chronic kidney disease, the disease that lead to chronic kidney disease, and you can see that on the top is the diabetes, next is the hypertension, then cardiovascular disease, other kidney diseases, multisystem disease like lupus nephritis, etc., and also family history of kidney disease in the family tree. So these are the conditions which leads to chronic kidney disease. Before the chronic kidney disease happens, this group of patients are at risk. That's why I have just you can see what terms is Ckd 0. That means in this stage they don't have any kidney problem, but they have the diseases which can lead to the kidney disease. That's why sometimes it can be called as pre-CKD condition as well. And you can see from this list, these are the major disease the community suffers from, and they don't know that one day they can develop kidney disease. Now the question is that when the kidney disease develops, only by two problems. One is reduction of the kidney function, that means GFR. When the GFR start to go down, in terms of the creatinine, serum creatinine, which we measure, goes up and exceed the normal reference rate, then we think we understand that kidney disease has started. Another parameter is the albuminuria or protein leakage in the urine. So even the kidney function may remain normal. The creatinine, which is the index of the kidney function, remains within the normal range. But if the person start to develop albumin excretion or protein excretion in the urine, he start to develop kidney function deterioration. And if this condition lasts for more than 3 months, this is diagnosed as chronic kidney disease already. So you can see that at the beginning, the patient may not have any kidney disease but have the conditions which may lead to the chronic kidney disease in matters of time. And these are the two simple things. One is protein leakage in the urine, the other is increasing the creatinine level, indicates that the chronic kidney is happening. And when it starts, the chronic kidney disease, CKD doesn't remain in zero stage or pre-stage. It start to become in the stage, the classical stages. Here you can see that I have elaborated in this slide. This slide is actually from our Ckd guideline. It's just a copy. You can see the Ckd point here. This chronic kidney disease, when it starts from zero state or pre-state, it start to from CKD 1, 2, 3, 3A, 3B, 4, and 5, like that. And this staging of 1 to 5 depends on the level of the GFR. For example, if the GFR remains within the normal range is 90 to 120 mL per minute. But if the patient have a protein leakage, as I told you earlier, then he's having chronic kidney disease. And with this normal GFR of 90 to 120 mL per minute, we designate as a CKD1. And after that, if it progresses, that means the management, in spite of the good management, or maybe the management was not proper, or the patient didn't know that he has a chronic kidney disease, because most of the time this disease is asymptomatic, the kidney function deteriorates. That means GFR start to drop. It drops to below 90, and when it remains between 60 to 90 milliliter per minute, we call it CKD stage 2. And then when it further drops to 60 to 30, we call it CKD stage 3, which is further divided into A and B. However, when the GFR drops further to 15, that means 15 to 30 milliliter per minute, then we call it GFR CKD stage 4. And when the GFR drops below 15, is CKD 5 stage 5. And ultimately, when the GFR drops to below 6, on an average, the patient requires renal replacement therapy in terms of dialysis or transplantation. This is one part of the GFR, which explains how the reduction of the GFR classifies a chronic kidney disease to an advanced state. Now, the proteinuria, as you mentioned, as you asked about the proteinuria, we measure in terms of albumin in the urine, albuminuria, or in laboratory terminology, we say urine albumin creatinine ratio. This is the index of measurement. So every normal person passes some albumin in the urine. There is about, say, 25 to 30 milligram in 24 hours. So we express in our laboratory parameters, that means urine albumin creatinine ratio. For simplicity, I'm telling that if its level is less than 3, it's called normoalbuminuria. That means every individual is supposed to pass this amount, and this is not abnormal, this is not pathognomonic. When the urine albumin creatinine ratio increases to 3 to 30, becomes 3 to 30, then we call it microalbuminuria. That means a small amount of albumin is excreting, is losing through the urine, which is not normal, which is abnormal. And then when the albumin excretion increases further, say about above 30, then we say that is macroalbuminuria. That means the patient is losing more albumin in the urine. And just remember that this albumin is coming from the kidney. That means kidney is leaking the protein from the blood to the urine. So the kidney is no good. So you can see that when the albumin level excretion increases, indicates that kidney is damaged more and more. So in spite of the stage of having some particular stage, suppose there's CKD stage 3, but he has macroalbuminuria, then the kidney is more damaged than the person with CKD stage 3 with normal albuminuria or microalbuminuria. So you can understand that when the kidney is damaged further, as indicated by the amount of the increased amount of albumin in the urine, the kidney is supposed to progress further, and there is a relatively bad kidney in relation to the Ckd history without any abnormal albumin excretion. In this way, in this chart, which is a Ckd chart, you can see that the color of the of the of the rectangles has been increased from green, which is considered green, go ahead, green light, like traffic signal green. Then the yellow, you see the yellow traffic signal, when it becomes yellow, that means you become alert. And when it further goes down, it becomes red, then stop, the kidney function is going to stop. And finally, when the left down, the right down corner, you can see the dark red, that means the kidney is gone and the patient will need renal replacement therapy. So as you mentioned, asked me earlier, how GFR and albumin excretion in the urine affects the progression of the Ckd. This picture, dedicated picture, which is international picture, every nephrologist have this picture in their brain, shows clearly that the better level of the glomerular filtration level, lower level of the albumin excretion in the urine indicates a better kidney than the worse level of the GFR, and increased level of creatinine is a bad kidney. So this will ensure you that the patient is progressing. Progressing means in terms of reduction of the kidney function, so that it will help the nephrologist to become cautious, to become conscious about his particular patient, and also the patient have a lot of things for him to do to help the physician to control the chronic condition. So I think I have answered your question of this relation of GFR and albumin in relation to the chronic kidney disease progression. Thank you.
Yes, doctor. Thank you. So, doctor, the second question is when we talk about a patient with diabetes mellitus, what are the
Yeah.
key assessment criteria for the physicians to predict that the patient is developing CKD?
Okay, thank you. This is a very difficult question, but a very important question, because you understand that the patient has diabetes, so the patient is in the community, right? The general physician, polyclinic doctors, normal doctors are seeing the patient to manage the diabetes, and the patient doesn't have any kidney problem right now, and the physician also doesn't know whether he has to do something to prevent further development of the kidney function, and also the patient doesn't know whether in future he will develop kidney function dysfunction or not, CKD or not. So this question is very, very relevant in terms of this chronic kidney disease. So here, that's why I use the term CKD 0, which is my own term. This term is not in the terminology of the clinical nephrology, not in the KDIGO, not in any nephrology society. Even in my SGH, in my department, they also don't know. Of course, I have presented this slide several times, this picture several times to the department, and also to our hospital governance, and also to our polyclinics, doctors, and other things by personal communication. But I'm just telling you that this patient who is suffering from diabetes, not to mention of the other common disease the patient also may have, like including the family history of the kidney disease, they one day may develop kidney disease. That's why they are at stage 0. So if we are conscious about this CKD stage 0, if the particular polyclinic doctors or general physician or family physician, whoever he may be, is a particularly concerned, then he will definitely go for his screening and remaining alert about the chronic kidney disease development. So what he will do? Yes, we have guideline in National Health Service. Kidney disease has a program. They say that when a particular patient is suffering from or suffers from some diseases like these, which can lead to chronic kidney disease in future, they should do kidney test, Ckd test, chronic kidney disease test. So basically, there is nothing. There is the estimation of renal function in terms of GFR, and also as we mentioned earlier slide, determination of albumin in the urine. So they need to check whether the patient have kidney disease or don't have. The patient with diabetes screening should include renal function in terms of GFR and urine test in terms of albumin excretion. we call urine albumin creatinine ratio, that is known as Ckd test. So this Ckd test is actually established guideline by National Health Service and is also a standard norm for any doctors dealing with the diabetes. Our endocrine colleagues in polyclinic, in hospital, they regularly do this GFR and also urine albumin creation. Once they are abnormal, they become conscious and they refer. So in this slide, I am just showing you that the same condition, diabetes and other things is there, and when you do this particular urea and electrolyte, which is expressed as GFR as well by the lab method, and this ACR, which indicates albumin creatinine ratio of the urine, they need to do irrespective of the stages. So when the patient is diabetes, the doctors, physicians in the polyclinic or general physician or family physician or whoever, endocrine specialist or whoever maybe is doing that, and then when it becomes abnormal, that means when there is a protein leakage, albumin leakage in the urine, that is called albumin 1, 2, 3. 1 means normal, 2 means micro, 3 means macro. Then and the GFR is normal range G1. Then they find that there is a problem with the kidney because he's losing albumin. So to answer your question, in a diabetic patient, when the patient doesn't have kidney disease, what we should do, or our colleagues should do, they should of course do the Ckd test, which is basically urine test for the albumin and the renal function in terms of GFR. When these are abnormal, they can go for further tests like ultrasound of the kidney, take the family history, and also they can refer to the nephrology specialty to look for other causes which might lead to the albumin excretion and reduction of the GFR other than diabetes mellitus the patient is having, because the patient can have other additional disease like nephritis and other things. So this is the approach that our physician can take when they deal with a patient with diabetes, when the patient doesn't have any kidney issues. I think I have answered this question. This is also another important, very important question, I must say, because when the patient develops end stage and they start dialysis or they get a kidney transplant, they don't die of kidney failure anymore. So how they die? They die because of heart failure, cardiovascular disease. Other than the sepsis or malignancy like common people or accident, etc., etc. But if nothing happens, no infection happens, no accident happens, no malignancy happens, ultimately the patient on dialysis or transplantation will suffer from will die one day, and that is the most commonly caused by cardiovascular disease, heart attacks, coronary ischemic heart disease. So how this happens? This is a very important in relation to your this interview and the patient's prognosis. I just want to highlight one of my slide which will explain you how the kidney and the heart is related, and the kidney disease lead to the heart disease, which ultimately causes the demise of the patient. So in short, if I can tell you, if I tell you, I should tell you that kidney disease and heart disease is related, and this is expressed in terms of cardiorenal syndrome. Cardiorenal syndrome. So there are several classifications of cardiorenal syndrome. There are several types of cardiorenal syndrome: heart affecting the kidney, kidney affecting the heart, chronically affecting, acutely affecting, etc., etc. So the question that you asked is a chronic condition, chronic kidney disease affecting the heart chronically, ultimately leading to the chronic heart disease and heart failure and demise from the heart attack. So this slide will show you how this happens. I am just elaborating the slide to answer your question. Suppose the patient is in Ckd stage 1 and 2, that means early kidney disease. This early kidney disease, and he has a good heart, but it doesn't mean that his heart is not affected, because the kidney is an organ which involves your whole body. It clears the whole body and is affected itself by any problems with your body. So when we elaborate this slide, we can see that in chronic kidney disease stage 1 and 2, you see the patient can have other metabolic syndrome like obesity, he may have smoking habit, and of course he can have hypertension. And if he is a diabetes affects the kidney, heart as well. He has can have high cholesterol, which the heart can be affected. So these are the general condition where the heart can be affected, and this condition can be worsened by the chronic kidney disease, by metabolic syndrome. And you can see other things also, that in chronic kidney disease, actually we consider that there's a chronic inflammation is going on because of the kidney sclerosis issues, kidneys perfusion issues, kidney abnormalities. This lead to a chronic inflammation which produces inflammatory byproduct which circulates through the blood throughout the whole body, and also reaches the kidney heart and affect the heart. Because of this chronic inflammatory products also damages the heart in many ways. It can affect the vascular endothelium, it can affect the myocardium, etc., etc. In addition to the other risk factors of the kidney, for example, if the kidney suffers from the nephritis is itself an inflammation. It has itself its own inherent problems, humoral problems, which can reach the heart and affect the heart. And when the kidney disease advances further, stage 3 and 4, this problem is added on by development of low hemoglobin, anemia, because hemoglobin is mainly controlled by the kidney hormone, what is known as erythropoietin. So erythropoietin goes down in chronic kidney disease, anemia develops, low blood hemoglobin, that affects the heart, anemic heart failure. Then there's uremic toxins. The toxins cannot be removed by the kidney, so uremic toxins, it accumulates in the blood, that affects the myocardium. Plus the kidney's function is to remove the water and also salt which are in excess. In chronic kidney disease, kidney cannot remove that, so there is a chronic congestion with the water load, chronic sodium load, etc., etc., not to mention of the ongoing chronic inflammation. So this chronic congestion affects the heart. It increases its preload, and it in terms increases the afterload. So in this way the heart is affected. As the CKD progresses further, you can see that the kidney function has dropped much lower, and there's a lot of problems with calcium phosphate metabolism. Calcium phosphate products goes up, it causes vascular calcification of the heart and other blood vessels. There's more congestion of the water, and there's more anemia, more malnutrition, all affects the heart. Plus there is a humoral mechanism like increased renin production, increased aldosterone, etc., etc., which also increase the hypertension and also worsens the heart perfusion. In this way, in a vicious cycle, as the chronic kidney disease progresses, the heart also gradually affected and its function drops. It develops low ejection fraction heart failure, which ultimately causes the demise of the patient. So this is the basic mechanism by which chronic kidney disease lead to the chronic heart disease. Next slide, they just summarize what happens pathophysiologically in chronic kidney disease that affect the heart. Basically, I explained to you increased renin, angiotensin, aldosterone activation in the chronic kidney disease affecting the heart. Then there's sodium retention, water retention. There's endothelial dysfunction explained to you by chronic inflammation. There's increased cholesterol, the blood problems, anemia problems, etc., etc., affects the heart. In addition, if the patient suffers from nephritis and they need to take steroid prednisone in large dose and for a long time, that also can affect heart, causes steroid cardiomyopathy. In this way, the heart is ultimately affected. And in this chart, you can see that as the chronic kidney disease progress in terms of years, and suppose the patient doesn't have any chronic heart disease, in terms of year, he develops heart failure, and as the time progresses, the incidence of heart failure increases in this one. And when the patient already have an existing heart disease because of the diabetes or hypertension, this effect is accentuated as the CKD progresses. The incidence of heart failure increases further. So this shows that how the CKD affects the heart. And this slide is another important slide. So far I mentioned about the GFR, chronic kidney disease, in terms of reduction of the GFR. This slide shows how the protein leakage in the urine affects the heart condition. This gray is a normal albumin excretion, I told you earlier, less than 3. The white block is microalbuminuria, which is 3 to 30, and the black bar is macroalbuminuria, which is more than 30 in the urine. So you see that as the amount of the albumin in the urine increases, the effect of these on the heart chronic cardiovascular disease also increases. So not only the GFR reduction affects the heart, also the proteinuria level affects the heart. So is a two-way insult on the heart from the chronic kidney disease. So this should explain how kidney affects the heart. We call so-called cardiorenal syndrome type 4 chronic kidney disease causing chronic heart disease. And we get, in terms of cardiologist nomenclature, we get left ventricle hypertrophy, diastolic dysfunction, aggressive and early coronary artery disease. With the formation of a fistula that we do for the dialysis, there is a blood shunting from the arterial system, the venous system, that also increase the preload of the heart. And also high level of inflammation and oxidative stress have negative inotropic and vascular effect on the heart. In this way, the heart disease accentuates in a case of chronic kidney disease over time, and that led to the demise of the patient. So I think, in short, I have answered your question about the relation of the chronic kidney disease affecting the chronic heart condition. So I think I have made you satisfied about answering this question. I think this is a very important question that you asked, and maybe I am not the right person to answer this question, which is very important on one side and also very specified and needs brilliant physicians to answer this question. But from my practice, I'll say that from my colleagues, my friends, the physicians, they're dealing with the diseases that lead to CKD. I mean CKD stage 0, and when they get early CKD 1 and 2 and 3 at best, the selection of the medicine is very important. As in the CKD, I already mentioned that you have to use, you try to use ACE inhibitors or ARB or mineralocorticoid receptor antagonists in terms of blood pressure control, and if the patient is proteinuria control, because they have renoprotective effect. And even in American society, in Medscape, we have seen that we usually, for one very important thing is that ACE inhibitors, just example is enalapril, and ARB, just an example of losartan or valsartan, you cannot combine together. That means you cannot give these two medicine together when the eGFR is less than 60, because in that case there is a high incidence of hyperkalemia, hyperemia, which may be life-threatening. That's why guideline prevents everyone to use a combination of ACE inhibitors like enalapril or perindopril and ARB like losartan, valsartan or telmisartan together. So you have to use one, and you can maximize it according to the tolerance of the patient in terms of hyperkalemia and also blood pressure control. That is one thing. The other thing is that you can combine this medicine with mineralocorticoid receptor antagonists, as I explained earlier, like spironolactone, eplerenone, and now new medicine is coming out is filrenone, which we participate in and been approved by FDA. So this combination is possible because they don't produce life-threatening hyperkalemia. So in the Medscape, they say that even suppose you are treating a CKD, stage 3 or stage 4A, and the patient is on ACE inhibitors and mineralocorticoid receptor antagonists together, and you notice that the patient is having a mild degree of hyperkalemia, high potassium more than 5, 5.2, 5.5, like that. What do you do? Will you stop both, or you stop one, continue other, or you do something else? The correct answer, what they suggest, they agree also, we agree and I agree, because these medicines are renoprotective. They prevent CKD progression at a faster state. They retard the CKD progression. So we try to keep the medicine together, these ACE inhibitors or ARB plus mineralocorticoid receptor antagonists, and advise the patient their lifestyle, the food, restrict the potassium containing food, and also treat the hyperkalemia by chronically or acutely by Rizorium. Can be given acutely, can be given chronic once every other day or every 2 days, etc. And also there are other medicines like Lokelma, sodium, zirconium is coming up. We are using that, which can be used chronically and also acutely. So they say that better treat hyperkalemia with medicine, better treat hyperkalemia with lifestyle and food style, but try to maintain this ACRB, either of the two, with MRI if the patient is on. So this is advice about the renoprotective medicine, which is also used as antihypertensive. Next is diabetes. So they say that SGL2 inhibitors, dapagliflozin, empagliflozin, etc., have a very good safety profile, especially on endothelial function of the heart and the kidney. So in treatment of diabetes mellitus, when the EGFR is more than 45 milliliter per minute, it's encouraged to use this medicine because they have a protective effect on the kidney and the heart. But when the EGFR is less than 45 ml, they don't suggest it because it causes further proteinuria, and also the benefit is not well achieved. This is about the glucose diabetes medicine. And other diabetes medicine for CKD patients, the diabetes medicine downhill or glibenclamide is a long-acting 24 hours half-life, and the short-acting are talbutamide, glipizide, gliclazide, etc. So is insulin also. There's a soluble insulin and mixture and long 24 hours insulin, lantus insulin. So in terms of glucose control in CKD, because in CKD renal excretion is reduced, the diabetes medicines also metabolize slowly. As a result, they accumulate. So if long-acting diabetes medicine like downhill is used, they will have hypoglycemic effect because they are not metabolized because of damage kidney. Kidney metabolize the diabetes medicine, including insulin. For CKD patient, that's why we use a short-acting oral hypoglycemic agent like glipizide, gliclazide, sometimes talbutamide, which are 8 to 12 hours half-life. And in insulin, we use the soluble insulin mixed with mixture, which is a 12 hours half-life. We try to avoid protamine insulin, which is a long-acting, but sometimes we use lantus insulin according to the endocrinologist's advice. This is about the insulin diabetic control. The other medicines, the patient frequently complains of pain and other things. Obviously, we have to use NSAID. We have to avoid NSAID, whether in the tablet form or local topical form. We have to use other options like Panadol, paracetamol with muscle relaxant, non-narcotic, obvious analgesic, etc. And sometimes we have to refer to the pain management team if the pain is very bad, and to exclude gout by doing uric acid levels, and here allopurinol. And for the pain, colchicine can be given as safe once a day or once other day. It's a safe medicine, colchicine, for the kidney gouty patient. And other medicines just have to take the dosage consideration in terms of EGFR, which is all standard, all physicians knows. So I think in terms of management, particular disease, particular medicine, you have to be a bit selective in terms of CKD friendly. And for renal protection, I mentioned also already that inhibitors, we try to use that. And then there are other medicines like your vitamin B6, which is reproductive in terms that it reduces oxalate metabolism, so it reduces oxalate load to the kidney. So we frequently try to use as pyridoxine. And then another very important thing is that ascorbic acid, vitamin C, which is a very common practice in general physicians, in polyclinic, and also in general practice. Many people take ascorbic acid in high dose over the counter also to prevent infection, flu, etc. But ascorbic acid itself is metabolized to oxalate in the liver, so it goes to the kidney and damages the kidney. So that's why in CKD patient, actually ascorbic acid should be avoided, the vitamin C. So patients may not have the knowledge, and many general physician also doesn't look into that. So our advice is that in terms of vitamins, try to avoid ascorbic acid, and no need to give artificially, additional medicines the patients are getting from the food enough, and try to give vitamin B complexes. And because we have restricted the foods for the patient's food, so they need some vitamin supplements like renal white, renal friendly vitamin, some iron supplements, etc. For the maintenance of nutrition. So this much I can say about the medical management of the CKD in the general practice.